Hello everyone, welcome to Apollo Spectra Hospitals, Kormangala, Bangalore. Today we have with us Dr. Sampath Chandra, who is our consultant skull-based surgeon, and the topic will be skull-based surgery.
Namaste, my name is Dr. Sampath Chandra Rao and I head the skull-based surgery section at Apollo Spectra, and today's discussion will be on skull-based surgery. So you may ask me, what is skull-based surgery? Skull base is a part of the face or the head, I would say, on which the brain rests. So a brain is resting on a flat bony area which is called the skull base. So this is hidden by the face and it's between the ears, behind the eyes, and it forms a bony foundation on which the brain is sitting. So any problem in this area is dealt with what is called skull-based surgery. Now, is surgery the treatment option for all situations? No. But when we do a surgery, that is generally done by skull-based surgeons. Similarly, behind the pretty face that all of us have, there are a lot of structures that go in and out, and they are all hidden by the face. There are arteries that go from the heart on both sides of the neck, going behind the face through foramina or holes that go into the brain. This carries good blood which goes from the heart into the brain. The brain then uses the blood and causes deoxygenation, uses the oxygen essentially and the nutrients, and this blood then comes down through what are called the veins. They also come through holes, so good blood goes in and bad blood comes down from the blood, and so these are the two most important structures, so arteries and veins. And there are not one or two, there are several of arteries that go into the brain and come down. And as arteries go through the neck, they also divide into various branches. It's like a tree, and they're all connected. So arteries between the left side connect with the arteries of the right side, and similarly the veins all are interconnected. So it's a very complex mesh or network of structures which exists behind the eyes, between the ears, and below the brain. The brain itself is a very complex structure which sends nerves from the brain downwards into various parts of the body, one of the most important structures being the spinal cord. So there are nerves that come out of the brain and they supply the face, they go into the neck, and they supply various other parts of the body. All these structures go through the bony foundation which is called the skull base. So apart from the nerves, the arteries and the veins, there are also other important structures like the eyes, there are the ears obviously, and there is the nose itself, which all form a part of the skull base, and all these are very, very important sensory neural structures. They form a part of our 5 senses. So let us say that there is a tumor that arises from any one of these nerves, arteries, veins, or any one of these structures. Where do they sit? They sit right in the center of the head, and the problem with any of these tumors and any of these lesions is that they are visible very late once the tumor is grown to a certain size, 3 centimeters, 4 centimeters, where they then cause neural effects, or they probably are frankly visible either through polyps coming through the ear or through the nose primarily. So the problem with any skull-based tumor is the fact that they are in vital areas, surrounded by vital structures, and they present late only after the tumor has grown to an extent where probably surgery, radiation or something has to be done, and it requires some sort of very definitive treatment. A tumor in one area can cause collateral damage by itself or due to the fact that it could be operated upon. So the third problem with skull-based tumors and with any lesion in that area is the fact that these are rare tumors. So in Apollo Spectra we have a skull-based center revolving around me, and I have been instrumental in setting up the centers for the last 4 years, and we have been hugely successful in dealing with a lot of complex skull-based cases. We have a team of 4 doctors dedicated to skull-based surgery, and we have a cochlear implant team as well to back up any hearing related issues that come up with some of these skull-based cases. So a good result can be obtained in skull-based surgery if there is teamwork, and secondly if there is good infrastructure. A lot of these areas are difficult to reach by, and a lot of areas are dealt with in a very minimally invasive way. So I need to dwell upon this subject of minimally invasive surgery. Earlier, when there was a tumor of, let's say, the pituitary, the surgeries used to be, or a CSF leaks. The CSF is cerebrospinal fluid, which is a fluid around the brain that cushions the brain. So sometimes if there's a leak into the nose or around the ear, these tumors, these lesions were always dealt with by external surgery, where a flap was, incision was put on the head, and a bone flap was elevated and the brain had to be retracted. Now such tumors or lesions are all dealt with endoscopically through the nose, around the eyes using supraorbital, infraorbital incisions, or also behind the ears or in front of the ears. So these areas are now dealt with in a minimally invasive way without scars being visible outside. So it's when we are talking about such minimally invasive procedures, we are talking about high dependency on infrastructure. And when I say infrastructure, I am talking about neuronavigation, nerve monitoring systems, neuroanesthesia, which requires anesthesia which is more superior to the routine anesthesia that is given, and we require good ICU facilities, because these patients are patients that need to be critically monitored in the first few days post-operatively in the ICU. So good intensive care units are all an integral part of a good skull-based center, and results can only be obtained when there is a good team in a good center with good infrastructure. So what are the treatment options? The treatment options that are available to a surgeon or a patient are of three types. If it's a very small tumor that is diagnosed very early, we could do what is called a wait and scan approach. A wait and scan approach is what I first offer if I see very small tumors in, let's say, in young adults or in elderly people, because I don't want to get into surgery which can be quite critical, challenging, all these things, if it's a very small tumor causing no problems and which was discovered accidentally. I would let the tumor grow to an extent where there would then where some form of intervention would be mandatory. So the patient then gets a reasonable amount of time to do other important things in life, like settle down in a job, get married and other things, and then the tumor can then be addressed. But this is in case of a benign tumor, a non-cancerous tumor. If it's a cancerous tumor, it has to be caught young and it has to be operated immediately. Now then again, what is the next option? Radiation can be another option to deal with tumors that are small or tumors that are seen, fairly bigger tumors which are seen in very elderly people, because in elderly people again don't want to operate. Radiation freezes the tumor, cannot eliminate a tumor, but it gives time, and in many cases that is all that we need, because in an elderly patient 75, if it gives us 10 years, then we really don't want to be worrying about anything else. Whereas in a younger patient, if we diagnose early, again if it gives 5-10 years, that could be very, very useful for a person who is just about to set his career. Now if there is a bigger tumor, 2 centimeters, 3 centimeters, 4 centimeters, then this has to be operated, because this has already become too big for it to be left alone, and secondly, it is going to cause more collateral damage either by the tumor itself or due to the surgery, and we do not want more collateral damage. So if there is a 2-3 centimeter tumor and above, I would offer surgery for any age of the patient. So there are these situations, and so treatment options can be tailor-made. Now if it is a cancer that can occur due to as a part of a carcinoma of the temporal bone, or some of the other lesions like rhabdomyosarcoma, chondrosarcomas, they can also be dealt by what is called chemotherapy as a part of surgery, chemotherapy, radiation protocol. So these things can be tailor-made and can be offered to patients on a case-to-case basis. In fact, at our center we've been able to do the first osseous implant alongside a skull-based tumor, and this was a landmark case where a patient from Iraq came to us with a long-standing history of Petrous bone cholestoma, 10-year-old history, and this young boy was operated upon at a center. Not only did we clear the disease, but we also put in a ossea, which is an implant used to restore hearing, which was destroyed due to the tumor, and the patient is now doing extremely well. We are also one of the first teams in and around this region, Middle East, Asia Pacific, India subcontinent, where we do simultaneous ipsilateral cranial nerve rehabilitation alongside tumor removal. Now this is a very long statement. What it essentially means is we not only remove the tumor, we also restore hearing by using implants in the same sitting. In the past, this was done in 2 stages. Very few people used to do this in India, but overseas this was done in 2 stages. That meant 2 surgeries, 2 anesthesia, double the cost. Whereas we have been able to do tumor removal as well as hearing rehabilitation in the same sitting. Now we went a step further in recent times. Over the last year, we have been able to do facial nerve reanimation also as a part of the same procedure, which means that not only when we have tumors that are affecting the nerve, especially the facial nerve, and when there is a paralysis of the nerve, and we see this in a lot of tumors in the lateral skull base area, we also provide surgery which does facial plastic surgery along with the same sitting, and in the same surgery we remove tumor, rehabilitate hearing by putting an implant, and we also do facial plastic procedures all in the same sitting, thereby providing the patient absolute relief in one single surgery. We get a lot of international patients from the Middle East, from Bangladesh, from Nepal, from other parts of Southeast Asia, and when they come, they don't want to come 3 times. So we've solved this problem by, yes, it's a little bit of a burden on the operating surgeon because we'll have to sit long hours, and I've operated, my longest surgery has been 30 hours where we did all the 3 things together in one patient and provide multimodality treatment in a single surgery, and we've been one of the only centers doing this, and we've been hugely successful, and this has brought in literally a smile on a damaged face in several of our patients. So if there is any pathology in the skull base that the physicians in the community need to refer to us, we'll be more than happy to take up the case. You can be in touch with my team, and if there is any patient out there who requires a minimally invasive skull base tumor excision or surgery for the skull base, kindly contact our center and we'll be happy to serve you. Thank you.